Okay, so today we're going to be talking about weaning and discontinuation of the ventilator. I probably have told you probably this before as far as weaning patients or just even extubating patients, probably more so extubation, that I remember a physician at Lutheran, Dr. Lapidus. I mean, we usually went through the process of weaning, but occasionally if a patient didn't have anything else underlying going on and they were just like a quick post-op for a simple procedure or didn't have any really underlying COPD or that, he always felt that if they had a strong cough and they could lift their head up off the pillow, that they were probably good to go to get extubated. So with that being said, the textbook also says too that about 80% of patients don't really need a gradual withdrawal process or a prolonged withdrawal process of getting them off the ventilator. This PowerPoint actually goes along with chapter 20, so just wanted to let you know that. But we do have those patients that are more difficult and more complex, and then with that being said, our job is trying to figure out what works best for these patients. We have different modes that we can try, so we'll be talking about that. Alright, so basically, when do we want to get patients off the ventilator? So when do we want to get these patients off the ventilator? Well, obviously as soon as possible, because the longer that we keep them on the ventilator, the weaker they get, the more diaphragm fatigue and muscle fatigue overall, and then the higher risk of infection. So we need to think of some of the different questions that we should be asking ourselves when we are extubating, considering extubation. Okay, so these should be questions that you should have in your head. Okay, because remembering if we extubate patients too soon, that can be associated with a higher mortality rate. So we need to be asking ourselves these questions. Are they able to protect their airway? How strong is their cough? Do they have excessive secretions? Were they a difficult intubation to begin with? So we need to be mindful of that. If they were, it should have been noted or passed on, so you want to make sure you have your difficult airway cart available. Maybe consider having the doc give a dose of steroids to see if to help reduce any swelling. Obviously we need to do a leak check. We should be doing leak checks anyway on patients now, just to make sure they're able to be extubated. They have a significant leak around their ET tube. What is their RSBI? And we'll be looking at that in more detail on the upcoming slides. How long have they been weaning? Is it a really good idea to extubate somebody who's maybe been on a wean for several hours, and they're starting to, at the end of their weaning, maybe they're going to be too fatigued, or it's just the end of the day. So a lot of times we'll wait, we'll rest them again that night, and then extubate them in the morning. What's going on with their underlying condition? Are they having a fever? Is their blood pressure stable? Do you foresee them going to the OR in the next day or two for something else, especially if it's like an MVA or something where they may need more repairs done? So just kind of having an overall picture of what is going on with the patient. Alright, so we have three common approaches. These are kind of more the traditional approaches, and we'll be talking about different modes of ventilation that technology has given us. But SIMV, pressure support, and T-piece. Okay, so we'll talk about those three different things. So a patient may require support during their weaning. Again, you could do SIMV with pressure support. Also, we need to, sometimes patients are going to maybe need a combination, or we may have to trial them on one or all of the above to kind of see which works out best for them. And then also seeing what type of an airway they actually have. Sometimes patients on trachs might actually do a little bit better on a TP swing. You just kind of have to see there's pros and cons, and we'll be talking about that here. So when we're looking at SIMV, the idea is to let the patients work and then have alternate periods of rest. Okay, so you generally have a certain rate that you give them. You start to titrate that down. However, you can have problems with this with vent asynchrony because the respiratory center doesn't know whether or not to initiate a breath. So there can be some problems with SIMV. So as a general rule, and we used to do this on our hearts all the time, is they would come out like on an SIMV of 12 or 10, and then every hour or two as they start to wake up. And again, these were just post-op, so they obviously had open heart surgery, but if they didn't have any other reason to be on the vent other than to be sedate for the procedure, their process was fairly quick. We usually would get them extubated fairly quickly, and we would drop their rate usually by about 2 breaths every hour or so as they start waking up. Back then we really didn't use a lot of pressure support. We just went ahead and cut the rate down, and then when they were like on a rate of 4 or so, we'd get parameters, just a tidal volume, respiratory rate, NIF, capacity, see how they were looking, and then get them extubated. But now we often use pressure support along with our SIMV, and that way we can kind of help support them during that spontaneous period with the tube, with the circuit and the ET tube itself, help compensate for the work of breathing. And that's generally set at about 5, but sometimes you may have to go up to 10. So everybody, make sure that when you are putting somebody on a wean, that you're not just pushing a bunch of buttons and turning around and walking away. You want to see what their baseline heart rate is, their blood pressure, are they awake, what happens if they drift off to sleep, are they getting something for pain, if they're having pain issues, are they going to be getting a lot of medication, or when the last time they had medication, is that going to affect them when they get those meds, and then kind of monitor and see what they're doing when they sleep, because some patients' tidal volumes aren't high enough for them to say that they're going to do well extubated. Of course, sometimes their CO2 needs just to go up a little bit to kind of stimulate that drive to breathe too. So that's always something to keep in mind, pain management. Alright, so pressure support ventilation again. The respiratory rate, mid-teens, mid-20s, it can kind of go up and down depending if they're being stimulated or what's, going on with them. Keeping the pressure support 5 to 10, or even says 15, but just keeping in mind the higher you're going up on the pressure support, the more you're actually supporting them, so maybe they're not a good candidate to wean. So those are things to kind of look at. The nice thing about being on CPAP or pressure support through the ventilator is that we do have our alarms in place. So whether we're using just pressure support itself, like 5 and 5, or 5 and 10, at least we have the alarms. Along with SIMV, we have the alarms. So we make sure that our alarms are appropriately set for our patients. So we have the tidal volume set tight enough, the respiratory rate, the overall minute volume, your apnea, you have that all in place to back up them if they do become apneic. So when we look at T-piece weans, that's definitely something that we lose when we put them on the T-piece. We no longer have those alarms. There's no backup for apnea. It has been shown that it's not well tolerated with patients with underlying heart disease, obviously severe muscle weakness, persisting chronic lung conditions. Some patients, panic with the idea of being off the respirator, the ventilator. You totally have removed that circuit. So sometimes it's kind of a psych thing where they may tolerate titrating them more on the vent, thinking they're still on it, they're getting oxygen. You have to kind of coach them through it. And then of course we have to be mindful of periods of apnea. So another idea would be to put an end-tidal CO2 in line to monitor their CO2. It just kind of depends on the patient, on how well they do. You will definitely see people coming out of recovery on T-pieces, and that's just a dry T-piece that they put them on from OR. So a lot of times they will come out of OR, the doc will put them on a T-piece with like a venturi, or sometimes they don't even have that venturi part on it. It's just like a small, regular oxygen tubing, small bore tubing connected to like a little adapter that has the T-piece part that actually connects to the ET tube, and then maybe like a link of corrugated tubing on the end, kind of seen here on the picture. But on the one end to the oxygen, it's just a small tubing. And basically they're kind of looking to see, are they picking up their respiratory rate? Are they breathing efficiently? They're kind of watching them during that short period of time. It's a few minutes. They've got their AMBU bag right there in case they have to bag them, but they're definitely looking to see, once I get to PACU, can we extubate them? Are they starting to wake up? Are they able to, are they reversing well enough? Of course, that's intubation rather for OR. So everybody's intubated for various reasons. So T-piece weaning can be accomplished through the ventilator. And this is basically when we're just putting them on CPAP. So when they're talking about T-piece weaning through the ventilator, they're just basically on spontaneous or CPAP. So there's no rate. So I guess you can call it T-piece weaning, but I call it CPAP weaning. All right. So we do have some newer weaning techniques with technology on our ventilators. Some different systems basically that we have certain parameters that we set, values that we expect the patient to be able to achieve, and then how the ventilator is going to support that. So we have ATC, which is automatic tube compensation. I do know that the 840 and the 980 have that on. You just have to go inside more settings and set that. I've been told that the 5 and 5 of CPAP and 5 of pressure support is pretty much equivalent to the same as actually using automatic tube compensation. So I guess it depends on your facility whether or not they like to use it. I know I have asked why we don't use it, and that was the answer that I got, was that in fact, it is on page 392 in your textbook. It says, in several studies, ATC was found to be equivalent of pressure support of 5 and CPAP of 5 in reducing work of breathing. So I guess at our facility, we just don't feel that it's necessary to put it on, because the 5 and 5 does the job, and we extubate from 5 and 5. So mandatory minute ventilation is another one we'll talk about. ASV, adaptive support ventilation, and then artificial intelligence systems. So these are basically considered closed loop systems. So like I mentioned before, there's a set variable that is compared with a measured variable. So we as practitioners set whatever variable that whatever the system is asking for, and then it compares it with what the patient's actually doing. And then the vent then uses a feedback signal to adjust the output of the system. So if the minute volume's dropping, it's going to make adjustments so that the minute volume can be higher. So each one of these has a little bit different variables that you can set. So automatic tube compensation is designed to decrease work of breathing associated with the ET tube and the circuit. It delivers the exact amount of support required to overcome the load imposed by the ET tube, provides variable pressure support. Again, in some studies it was found that the 5 and 5 was just as successful as setting an ATC. Alright, another one is called volume targeted pressure support ventilation. You can find this on the servo. It's basically pressure support ventilation but with a volume target. So it provides a set tidal volume while using pressure support criteria. So we generally want a tidal volume of about 4 to 6 mils per kilo, or at about a tidal volume at about 3 to 600 is what you're looking at. And it gives a test breath to the patient and then measures the volume delivered. It also looks at lung compliance and then adjusts whatever pressure is needed to achieve that set tidal volume. So that is volume targeted support ventilation, and that is talked about on page 392. Mandatory minute ventilation. This is available on the Drager Avita. The ventilator is going to automatically adjust to maintain a set minute volume. So what it does is maintains that set minute ventilation by adjusting pressure, frequency, or tidal volume. So the target minute ventilation is set slightly below the patient's actual minute ventilation. So approximately 80% of the patient's previous minute ventilation. If the patient's either hypocapnic or alkalotic, that's kind of like a guideline of where to set it. Some of the advantages: it may offer greater control of patient's PaCO2 than IMV. Acute hypoventilation or apnea does not cause sudden hypercapnia, but some of the disadvantages is that just as long as that minute ventilation is being met, it doesn't recognize how it's being met. So you could have rapid shallow breathing, and that's kind of going to fool the ventilator in thinking that it's getting its minute ventilation that you've set. But if you actually look at your patient, they are, breathing, their work of breathing is probably up because they have higher rates and lower volume, so they're going to fatigue. More research is needed on its effectiveness, but it's one of the modes that are out there. Adaptive support ventilation. This is available on the Hamilton G5. This again increases or decreases support based on monitored patient parameters. So the respiratory rate and the tidal volume are selected by a ventilator's algorithm to provide the minimum work of breathing for the patient. So it provides pressure limited breaths that actually target a volume and a rate. So the rate and the tidal volume are selected by the ventilator's algorithm to provide minimum work of breathing. The RT sets these parameters based on the patient's ideal weight, high pressure limit, PEEP, FiO2 rise time, flow cycle, and percent of predicted minute ventilation desired. So it is designed to decrease the work of breathing and decrease auto PEEP. So AI Systems is on the Draeger. This also uses predetermined ranges for your volume, frequency, and end tidal to adjust an inspiratory pressure automatically to maintain the patient in a respiratory zone of comfort, is what they call it. So the patient's readiness for extubation is based on achieving the predefined lowest level of inspiratory pressure, and once that lowest level of inspiratory pressure is achieved, a monitoring period begins. So the vent then continuously looks at the frequency, tidal volume, and end tidal, and if the patient has successfully passed the modified spontaneous breathing trial, the system then actually will display a message for you to separate the patient from the ventilator. So it's kind of monitors itself to kind of see whether or not they feel that the patient's ready. I would still double check everything myself just to see how they're looking. Ventilators can't replace our eyes. Alright, so muscle strength, is it important? Well, I hope you're saying yes. The parameters that we look at to see how to help us evaluate muscle strength are obviously respiratory rate, tidal volume, which is going to result in our RSBI, remembering that's respiratory rate or frequency divided by tidal volume. We would like to have that below 105, normal range being between 60 and 105. If it's greater than 105, then our patient's not ready to wean. And then our vital capacity. So answering the question here of which of these measurements may not be an accurate indicator of vent discontinuation. So pause for a second, see what you think about that. I am hoping that you answered a vital capacity. It's really hard to do a true vital capacity with an ET tube in your mouth. So that's probably not the best indicator. Keeping in mind if our respiratory rate is greater than 30-35, they're probably not ready to wean. They're ready to extubate. I mean, they can go up for short periods. Let's say you turn them, reposition, you suction them, they cough a little bit, their rate might go up for, as long as they're able to recover and maintain their sats and not go crazy on their heart rate. Another parameter that we can look at is called the P100 or P0.1, and that is looking at the drive to breathe. So the airway is basically occluded during the first 100 milliseconds of inspiration, and there's a occlusion pressure that's taken. So it kind of looks at the drive to breathe and ventilatory muscle strength. So you'd like to have a normal of about 0 to negative 2.0 centimeters of water pressure. A low P100 may indicate weak drive or muscle weakness. It's not really the best indicator. So less than a -6, it might mean that your patient's may not be doing so well. They might not be ready to wean. A high drive to breathe can still lead to muscle fatigue. That's why it's not the best indicator. High occlusion pressure may indicate that the patient is uncomfortable. So it can be misleading basically. It needs to be studied more. So I think caution leads to inaccuracy basically, or not really a good indicator. All right. So obviously, again, we mentioned that muscles will become weak after being on the vent for a long time. We definitely need to be concerned about malnourishment because it's affecting the diaphragm. One of the ways to measure work of breathing is called CROP. It's basically a calculation of your evaluating lung compliance, respiratory rate, oxygenation, and inspiratory pressure. Okay, so you've got your CROP, I guess, to get to crop. So it can tell you about muscle overload and fatigue. So we look at dynamic compliance. So hopefully you remember how to calculate that. Always think dynamic. You're going to use the PIP, P-I-P. Okay, so you have tidal volume divided by, remember, mils per centimeter of water. So tidal volume divided by PIP minus your PEEP. Okay. In this case, the P max is your actual maximum inspiratory pressure. Okay, and then F being your frequency or respiratory rate or frequency. You're looking at your PaO2, your arterial partial pressure of oxygen, divided by your PA, your big AO2, which you figure out by multiplying your FiO2 times your barometric pressure. Don't forget your water, minus your PaCO2 times 1.25. So a value of greater than 13 after doing all that math can indicate a likelihood of success. All right. So looking at things that we need to look at when we are determining readiness to wean, we need to consider all these: neurologic factors, respiratory factors, metabolic factors, hemodynamic factors, and psychological factors. I think when we look at a lot of these different factors, we kind of forget about the psychological factors. You know, it's easy to look at respiratory factors, metabolic factors, hemodynamic factors, but the psychological part can be a big part of it. We have to, you know, see how to address their fear, anxiety. Some of them become delirious, they have ICU psychosis, they can be depressed, angry, fear of being short of breath. So just reassuring them that that you're there, that you're monitoring them closely, you know, trying to sidetrack them maybe if they have a favorite television show or something to watch. You know, sometimes family members can help, sometimes they can hinder it. Sometimes they're too much of a coach where they're making them too aware of it. You know, having them sitting upright, you know, optimizing their success, you know, in the morning after, you know, you just kind of have to like put everything together. Like maybe after they've had a bath or something, or they've been moved around a lot, maybe that's not the best time to wean. Maybe let them get a little rest in. Just kind of find out what is their best time of day. Because, you know, if they get to that point where they're really short of breath and, you know, you're not able, you know, you're not switching them close enough and you've kind of pushed them over that edge a little bit, they're going to be really reluctant to try it again the next day. So, you know, even sometimes, you know, 2 to 3 weaning periods, you know, spread out throughout the day might be better than one long period. So it just kind of depends on the person. You have to kind of work with that, you know, see if they can get something for their anxiety, but obviously something that's not going to suppress their respiratory status. All right, so obviously you want to watch your patient closely. Just think for a minute, what parameters are you watching? So I hope you said the respiratory rate, your tidal volume return, making sure you're looking at your heart rate, the rhythm, their SAT, their overall appearance, if they're becoming diaphoretic, just kind of like the look in their eyes. So you should be looking at all of that, you know, monitoring their secretions. Are they able to cough okay? What's happening when they're asleep? how well do they recover after being, messed around with, meaning, if you're, suctioning them or turning them, are they able to recover okay? So it says, how long should we wean a patient before we extubate them? 77 to 85% of the patients who pass their spontaneous breathing trial can be extubated, usually without reintubation. It's very individual. You have to kind of see what works best for them. Keeping them in mind. Hopefully we're extubating without having to put them on BiPAP, but assuring them. Some of them have experienced BiPAP, non-invasive, prior to being intubated. Assure them that it's something that we could do again if we needed to, but hopefully, we're not going to have to head down that road again. So some of the different numbers that we're looking at, we'd like to see valve capacity of about 15 mils per kilo, minute ventilation about 10 liters, tidal volume 4 to 6 mils per kilo, keeping the respiratory rate less than 35. I mean, if it's hanging low 30s, I'd just be asking myself, why are they breathing that fast? But if it's a neural patient, sometimes they are. RSBI less than 105, making sure that they're synchronous and looking at their compliance. Some of the other numbers that we look at are dead space. Dead space tidal volume ratio, we'd like to have that less than 0.6. For sure, a NIF of at least -20, so the higher the number, the better. A PaO2 of at least 60 on 40%. PEEP less than 8. I mean, that's in the book. It says actually 5 to 8. I prefer less, like 6, 7. PF ratio above 250. A to A, your A divided by A ratio above 0.47. Your A to A gradient less than 350 on 100%. And I'm trying to find where all these numbers are listed again. They're in chapter 20 here. Let's see. They are on page 397. So make sure that you are indeed reading your textbook. A shunt less than 20%. Alright, so putting them on a spontaneous breathing trial, generally it's something that is usually started in the morning. They have hopefully put them on a sedation vacation to actually check parameters first. Okay, so I prefer to check parameters on 0 and 0, meaning I take off the PEEP and the pressure support and just see what they can do just for that minute while you're actually doing parameters, and then putting them on the trial at like 5 and 5. So anywhere is from about a half hour to 2 hours. I actually have an article that I'm going to have you guys read too as an assignment about weaning. It's a fairly short article, but I want your feedback on that. So things again that we're looking at, retraction, their diaphoretic, how anxious they are, tachypnea, tachycardia, and your RSBI. These are all things that you should be looking at, including all these other numbers too. Looking at their tidal volume, depending on the size of the person. If they're only hanging if they're less than 250, 200, and that's where they're hanging and their rates are creeping up there, I get a little nervous. Blood pressure changes, a drop of 20 on the systolic or a rise of 30 or greater than 180, a change of 10 on the diastolic, heart rate increasing more than 20% or greater than 140, looking to see if there's a change in rhythm, if they've started having some PVCs, and again if they're diaphoretic. So, extubation, obviously we have risks, potential airway obstruction, they can have edema, aspiration of secretions. You want to definitely make sure that you've suctioned them well prior to and suctioned above the cuff before you drop the cuff. making sure they're having a good cough so they can help cough the tube out. Think about what other things that you can do to hopefully minimize the possibility of re-intubating these patients. So I'm letting you think for a few. Maybe you should write these down. Checking to see if they have a cuff leak. Okay, especially if they've had a difficult intubation, you want to make sure that they have a cuff leak before you pull that tube. Making sure that their head of bed is up, making sure they're in a good position. Again, making sure that they have a strong enough cough, that we don't have to constantly stimulate them to get a cough, that they're able to cough on command and they're pretty much alert and oriented. They might be a little confused on the day. I'm even confused on the day. But making sure that they can cough on command, they can clear their secretions, they know how to use their yank hour. One thing to keep in mind is being careful with extubating babies after they've had a feeding. So, because that's going to definitely put them at risk for aspiration and regurg. Okay, so like I said, there will be an article to read as your check-in for this particular day, this is going to be for Wednesday, this lecture. Wednesday, April Fools. So I will have a discussion board posting that I want after this lecture, and I will put that up on the discussion post myself with replies that I would like from you guys.